In this presentation, we will explore the pulmonary pedicles, their anatomical composition, clinical significance, and role in imaging. Understanding these structures is essential for interpreting chest radiographs and diagnosing various thoracic conditions. To do so, we will start with a brief introduction, followed by detailing the constituent elements of the pedicles, including their functional and nutritional aspects, the anatomical relations of these structures, some key clinical notes and applications, and finally a conclusion in order to summarize all the key points. The pulmonary pedicles are formed by the extrapulmonary segment of the bronchial, vascular, or nerve elements that enter or exit the lungs. Each pedicle consists of a functional pedicle, which includes the bronchi, the pulmonary arteries, and the pulmonary veins. The pulmonary pedicles consist also of a nourishing and trophic pedicle, which includes the bronchial arteries, the bronchial veins, the bronchial nerves, and the lymphatics. We'll start by detailing the different constituent elements of the functional pedicle, starting with the bronchi. The bronchi originate from the tracheal bifurcation at the level of T4, towards the back, at the height of the Louis angle, and slightly to the right of the midline. They then diverge, forming an angle of approximately 70 degrees. The right main bronchus extends from the tracheal bifurcation to the superior lobar bronchus. It is almost vertical. It successively gives rise to the superior lobar bronchus, the middle lobar bronchus, and the inferior lobar bronchus. The left main bronchus extends from the tracheal bifurcation to the superior lobar bronchus, and is almost horizontal. It gives off the superior lobar bronchus, then continues as the inferior lobar bronchus. Moving on to the pulmonary trunk. It originates at the pulmonary orifice, located at the base of the right ventricle. It courses posteriorly, to the left, and slightly upward. It terminates behind the left border of the ascending aorta, where it bifurcates into right and left pulmonary arteries. The pulmonary trunk has a length of 5 centimeters and a diameter of 30 millimeters. The right and left pulmonary arteries, originating from the bifurcation of the pulmonary trunk, will divide into lobar arteries, segmental arteries, and subsegmental arteries. Let's talk now about the right pulmonary artery. The right pulmonary artery is longer and larger, measuring 5 centimeters in length and 22 millimeters in diameter. It transverses the mediastinum, passing next to its different structures. It passes behind the ascending aorta and the superior vena cava, above the transverse pericardial sinus, below the aortic arch and the arch of the azygous vein, and in front of the tracheal bifurcation. It enters the right lung hilum, positioned anterior and inferior to the origin of the superior lobar bronchus. It curves, passing above and then behind the middle lobar bronchus. It descends along the posterolateral border of the inferior lobar bronchus. And finally, the right pulmonary artery terminates at the posterior surface of the posterior basal segmental bronchus. During its course, it gives off multiple collateral branches. For the right upper lobe, typically 2 or 3 arteries. The mediastinal artery of the right upper lobe, that gives a branch for each segment of the upper lobe. And 1 or 2 fissural arteries, generally supplying the dorsal segment. For the right middle lobe, usually 2 arteries, originating from the right pulmonary artery at the depth of the fissure, each supplying one of the 2 middle lobe segments. For the right lower lobe, typically 1 artery per segment. An apical segment artery, and a basal segment artery. Let's discuss now the left pulmonary artery. It is shorter and smaller in diameter than the right pulmonary artery. It measures 3 centimeters in length and 18 millimeters in diameter. From its origin, the left pulmonary artery is immediately part of the left pulmonary pedicle. It ascends in an almost sagittal direction, passing in front of the left main bronchus and above the left upper lobar bronchus. It then descends along the posterior surface of the left upper lobar bronchus and continues along the posterolateral border of the left lower lobar bronchus. It terminates at the posterior surface of the posterior basal segmental bronchus. The left pulmonary artery gives the following branches during its course. For the left upper lobe, the superior mediastinal artery or apicodorsal artery, the anterior mediastinal artery or ventral artery, the dorsal fissural artery, and the lingular fissural artery. For the left lower lobe, the left pulmonary artery gives the apical segmental artery for the lower lobe, and the basal artery, branching to supply each segment of the basal pyramid. Let's delve into the pulmonary veins. The pulmonary veins, or perilobular veins, arise from the perialveolar network and, to a lesser extent, from the peribronchial and subpleural networks. Inside the lung, the veins are located at the periphery of parenchymal territories, within the interlobular septa, and then in the intersegmental or perisegmental planes. On the right side, there are two pulmonary veins. First, the right superior pulmonary vein. It drains the upper and middle lobes. Positioned in the anteroinferior part of the pulmonary pedicle, it is formed by the union of two tributaries. A superior tributary, that drains the upper lobe, and an inferior tributary, that drains the middle lobe, and the right inferior pulmonary vein, that drains the lower lobe. It is located at the inferior part of the pulmonary pedicle, and if formed by the union of two tributaries, one superior and the other inferior. There are also two left pulmonary veins, superior and inferior. The left superior pulmonary vein drains the upper lobe, and the left inferior pulmonary vein drains the lower lobe, following a pattern similar to the right inferior pulmonary vein. Next, the nourishing pulmonary pedicle. The bronchial vessels provide the nutrient vascular supply to the lung and are subject to significant anatomical variations. Starting with the bronchial arteries. On the right side, there is usually a single right bronchial artery, which typically arises from a bronchial intercostal trunk. It crosses the esophagus, most often posteriorly, and reaches the posterior surface of the right main bronchus, where it branches. Whereas on the left side, there are typically two left bronchial arteries, classified as superior and inferior. They generally originate directly from the descending thoracic aorta and rapidly reach the left main bronchus. Now onto the lymphatics. The lymph nodes of the pulmonary pedicles are located between the bronchovascular elements and are classified into the anterior lymph nodes, located in front of the bronchial plane. They include the prevenous node, positioned anterior to the inferior pulmonary vein, the prearterial node, located anterior to the pulmonary artery, the prebronchial nodes, situated in front of the bronchus, just before the origin of the upper lobar bronchus, the posterior lymph nodes, positioned on the posterior aspect of the bronchus, the superior lymph nodes, located above the bronchial plane, and the inferior lymph nodes, aligned along the inferior border of the bronchus. With this in mind, let's continue with the bronchial nerves. The bronchial nerves are arranged into two plexuses, an anterior plexus and a posterior one. They are formed by branches of the pneumogastric nerves and pulmonary branches of the sympathetic nervous system. Now, let's shift our focus to the anatomical relations of the different elements of the pulmonary pedicles. Starting with the right pulmonary pedicle in its mediastinal segment. The mediastinal segment is related, anteriorly to the superior vena cava. The latter largely conceals the pedicle, its terminal part is enclosed in the pericardium. Over there, the right phrenic nerve descends, accompanied by the right superior phrenic vessels. Superiorly, the mediastinal segment is related to the azygous arch and the right latorotracheal lymphatic chain, or arch ganglion. Posteriorly, the azygous vein, before forming its arch, and the right vagus nerve. Inferiorly, the triangular ligament, accompanied with the inferior vena cava, and the right atrium. Let's tackle the hilar segment of the right pulmonary pedicle. At this level, it corresponds to the margins of the hilar fossa, which are lined with pleura that invaginates into the fossa. Moving on to the left pulmonary pedicle on its mediastinal segment. The left pulmonary pedicle is shorter and less extensive than the right. It corresponds to the aortic arch anteriorly. Its initial part are encased in the pericardium, on which the left phrenic nerve descends, accompanied by the superior phrenic vessels. Superiorly, the aortic arch, sometimes leaving an impression on the bronchus. The left recurrent laryngeal nerve, looping under the aortic arch. And the ligamentum arteriosum. Posteriorly, it is related to the descending thoracic aorta. The esophagus. The thoracic duct. And the left vagus nerve. Inferiorly, it is related to the triangular ligament. The left atrium and the left ventricle. The relations of the left hilar segment are the same as on the right. However, the left hilum is more central and positioned higher. And there are only 2 lobar pedicles. Building on what we just discussed, we will now transition to some key clinical applications in understanding some conditions and pathologies, such as hemoptysis. Hemoptysis is defined as red, aerated blood of subglottic origin expelled through the mouth during a cough effort. It indicates the passage of blood from the thoracic vascular system into the airway and serves as an alarm symptom requiring urgent etiological investigation. Severe hemoptysis is life-threatening due to the risk of asphyxia. Thoracic imaging is crucial, with volumetric CT angiography providing a comprehensive, non-invasive assessment. Endovascular treatment is the first-line invasive approach, primarily involving bronchial artery embolization, in over 90% of cases, with pulmonary artery vaso-occlusion being necessary in fewer than 10% of cases. By way of conclusion, knowledge of the pulmonary pedicle anatomy is very important for understanding certain cardiopulmonary pathologies, interpreting thoracic radiological exams, and performing certain therapeutic interventional procedures.